which we are going to discuss in cardiac physiology are the heart murmurs. So normally the blood flow in the vessels is streamlined. That streamlined flow does not cause any sound. It is streamlined normally. But whenever there is turbulent flow of blood, the turbulence causes a certain sound which we call murmur. And if this murmur is palpable, we call it a thrill. So the heart murmurs are divided into systolic murmurs and diastolic murmurs. We will study each of them. So the systolic murmurs are the aortic stenosis, the pulmonary stenosis, the tricuspid regurg, mitral regurg, Hockham, MBB, and VSD. Now, how to remember these is look at the heart chambers. Heart has 4 chambers: right atrium, left atrium, left ventricle, and right ventricle. So the two superior walls are aortic valve and the pulmonic valve. The pulmonic valve arises from the right ventricle and the aortic valve arises from the left ventricle. So the stenosis of the two superior valves, aortic and pulmonic, is systolic, while the regurg of the two inferior valves, the tricuspid and the mitral and the tricuspid valves connects the right atrium and the left ventricle. They are located here and here respectively. So the regurg of these two will produce systolic murmur. So the stenosis of the superior valves and the regurg of the two inferior valves will produce systolic murmur. Similarly, VSD, you remember that it has a hollow systolic murmur, so it is easy to remember. Similarly, MVP and Hockham, these two usually come together. We will discuss them later in detail. So all these produces systolic sound. This is just a way to remember these. We will discuss them. The diastolic murmurs are the regurg of the two superior valves and the stenosis of the inferior valves. The mitral and tricuspid valve stenosis, while the aortic and pulmonic valve regurg, they produce diastolic murmurs. Now the systolic murmurs, they may be physiological or pathological, but the diastolic murmurs are always pathological. Now there are different types of grades of murmur. The grades of murmur there are 6 grades of murmur. Grade 1, it is a very faint murmur. Grade 1 is barely audible in a quiet room, and grade 2, it is faint but it is audible. Grade 1 is very faint and it is barely audible. Grade 2 is faint but it is audible. Grade 3 is easily audible but it has no thrill. And if it has a thrill, then we call it grade 4 murmur. Similarly, grade 5 murmur is a very loud murmur. It is audible outside the pericardium as well, anywhere in the chest you can hear this. And grade 6 murmur, it is heard without stethoscope as well. So this is a very, very loud murmur. So these are different grades. Sometimes you can hear them barely, they are audible, and sometimes they are very loud. Further, if we discuss each one of them in detail, so the first murmur is aortic stenosis. The aortic stenosis, how this develops? The aortic stenosis, as the name indicates, it is stenosis of the aortic valve. So when the aortic valve is stenosed, what will happen? When the aortic valve is stenosed, what will happen? The aortic valve arises from the left ventricle, outflow tract. Here it is the aortic valve. So when it gets stenosed, what will happen? The back pressure will increase. So what will happen to the left ventricle? The left ventricle pressure will increase much more than the aortic pressure. So it will increase much more. For example, it is 160 and it is greater than the aortic pressure is usually 120. So it is much more. So the gradient between the two is increased. The pressure difference between the two is increased. And with time, when the aortic valve root it falls between less than 0.7 centimeter, it falls less than 0.7 centimeter, what happens is the left ventricular starts hypertrophying. It gets bigger, and eventually it hypertrophies, and eventually it fails. So when it fails, it results in angina and syncope and heart failure. And the second thing it causes is sometime it after hypertrophy, when it eventually dilates and increase in the cavity size occurs, then the mitral valve annulus is also pulled apart. Here is a mitral valve, so that annulus is also pulled apart, and that causes mitral regurg. In very severe cases, it causes mitral regurg. Why this aortic stenosis happens? This aortic stenosis is because of the calcification of the abnormal bicuspid valve. Sometimes in the elderly, what happens is the aortic valve normally it should have 3 cusps, but it has 2 cusps and they are stenotic. So that causes aortic stenosis, and it increases the back pressure, and sometimes rheumatic fever also causes this kind of condition. So let's discuss it here. Aortic stenosis. What kind of murmur will it produce? It will produce crescendo decrescendo murmur. Crescendo decrescendo ejection systolic murmur. What does it mean? That the murmur will increase and then it will decrease. So it is like a, if you look at its shape, it is like a diamond shape. So it produces a diamond shape crescendo decrescendo ejection systolic. Ejection, which is loudest at the heart base, and it radiates towards carotids. This is very important, that the murmur of aortic stenosis radiates towards the carotids. We also call it pulsus parvus et tardus. What does it mean? That pulsus parvus means that weak pulse. That you look here, it the upstroke is very weak, and then it has delayed peak, and then it comes down like that. So it happens in the elderly, and most commonly it is due to age-related calcification. And in younger, it is due to calcification of the bicuspid when the shape is bicuspid. So it leads eventually when the left ventricular hypertrophy occurs, and it can no longer cope with the higher pressures. So it results in syncope and angina, dyspnea. So you can remember it with the sad mnemonic. And another thing is that it also causes a soft S2. A soft S2, or sometimes S2 is single. Why is it single? We discussed it in previous video as well, that normally during inspiration, what happens is there is venous return is increased. Venous return is increased. Why is venous return increased? Because the intrathoracic pressure it drops, so it sucks the blood into the right side of the heart. When the right side of the heart is filled with blood with increased venous return, what it causes in return? That the pulmonic valve it opens slowly than the aortic valve. Normally during inspiration, there is the A2 comes earlier than the P2. Why? Because the right side of the heart is still dealing with the blood, while the left side just pumps it out because of the increased venous return on the right side. When there is aortic stenosis, this valve opens late because it is stenosed. When it is stenosed, so the P2 is already delayed. The P2 is already delayed during inspiration. When it is already delayed, and the A2 is also not opening because it is stenosed, so the two sounds merge with each other. When the two sounds merge with each other, they appear as a single sound. So in the expiration, the split happens. The expiration normal split happens, but during inspiration the two sounds seems to be together because it is stenosed. And in the inspiration, in the expiration, why the split happens? Because the P2 is opening earlier, earlier in the expiration, because there is no venous return. In the inspiration there is increased venous return, due to which the P2 is delayed and the A2 is delayed in both the phases, both the expiration and the inspiration. So we see a paradoxical split. We see a paradoxical split means that the it is splitting in the expiration in contrast to inspiration as normally it should happen. If you do not understand this concept, then refer to the previous video. I discuss it in great detail there. So normally, what kind of murmur is in aortic stenosis? Crescendo, decrescendo, ejection systolic. It radiates towards the carotids, and then there is a soft S2 or a single S2. Now let's discuss the second murmur, mitral or tricuspid regurg. It produces hollow systolic high pitched blowing murmur. Hollow systolic means that the murmur is there throughout the systole. It starts at S1 and ends at S2, and it is throughout the systole. It is called hollow systolic. It is high pitched blowing murmur. So how the mitral or the tricuspid regurg happens is, for example, this is there is the right side of the heart, and there is a tricuspid valve. There is a tricuspid valve, and there is the mitral valve. So what will happen in the mitral regurg? Normally in the mitral regurg, when systole happens, the wall should close completely, and the whole left ventricle should contract isovolumetrically, when both the aortic and the mitral valve should be closed at that time. But due to mitral regurg, this valve remains leaky and it does not close completely. So what happens during systole, that some of the blood trickles back into the left atrium. Now what happens is, this mitral regurg, this increases the left atrial pressure. So the left atrial pressure is constantly increases, and it causes back pressure. So how will it cause the back pressure? That gradual elevation of the left atrial pressure in the setting of dilated left atrium, it will eventually results in the pulmonary hypertension. That back pressure will develop in the lungs, and it will result in pulmonary hypertension and chronic backflow into the pulmonary vasculature. Why this mitral regurg happens? So some of the causes include endocarditis, most often due to Staphylococcus aureus. It also happens due to papillary muscle rupture. If any of this muscle rupture, for example, after MI, post-MI, this is one of the complication, post-MI complication, that it causes mitral regurg. Also due to mitral valve prolapse or any other cardiomyopathy, this valve becomes leaky and it increases the left atrial pressure constantly, which increases the back pressure. So similarly, what happens in the tricuspid regurg is, it is due to the failure of the tricuspid valves to close completely during systole. So what happens is, the regurg of blood occurs in the right atrium. So normally a mild physiological tricuspid regurg is seen in adults, but if it is much more, then we consider it pathological. And what happens, what is the most common cause of the tricuspid regurg? The most common cause is the left ventricular failure. When left ventricle fails, back pressures occur, and this is the most common cause of the right-sided heart failure as well. Now, one of the important thing is that this tricuspid regurg, it is most common in IV drug abusers, because this is the right side valve. So whenever they inject any kind of drugs on their veins, so it directly affects the right side valves. For example, in the infective endocarditis, in IV drug abusers. Similarly, in Epstein anomaly is a congenital anomaly in which the tricuspid valve is downwardly displaced, so it becomes leaky and regurgent. And there is also some other condition like SLE, myxomatous valve degeneration, and other such conditions. But the most common cause of the right-sided heart failure is the left-sided heart failure. And what will happen when this tricuspid valve become regurgent? When the tricuspid valve become regurgent, it will create back pressure. So the right side of the heart, it receives blood from most parts of the body, so it will result in ascites. It will result in ascites. It will result in hepatomegaly, because the pressure here are enlarged, so it will not be able to receive all this blood. Hepatomegaly, ascites, and similarly edema. So whenever there are right-sided heart failure, the following symptoms occurs: edema, raised GVP, etc. So let's discuss it here. It produces a hollow systolic. It means it is throughout the systole. It is high-pitched blowing murmur, and it is loudest at the apex. It radiates towards the axilla. So you have to remember this, that the murmur of the mitral regurg, it radiates towards axilla. It is very important point. And the tricuspid, it is loudest at the tricuspid area. Only the mitral regurg, it radiates towards the axilla. And it is often due to ischemic heart disease. MR is due to, I discussed it, that it is one of the complications, post-MI complication. Similarly, MVP and any reason of left ventricular dilatation will cause MR. Similarly, rheumatic fever, it has a close association with MR. And the tricuspid regurg, often due to right ventricular dilatation, and it is either due to a complication of the mitral regurg or the tricuspid regurg or infective endocarditis. In IV drug abuses, it causes right-sided valve damage. So let's move to the next one, mitral valve prolapse. Mitral valve prolapse, it produces a late crescendo murmur with mid-systolic click. How mitral valve prolapse happens is that there is myxomatous degeneration of mitral valve leaflets, or there is excessive myxomatous tissue. So that excessive tissue causes what? That whenever the mitral valve it closes, it produces a click in between the S1 and S2, mid-systolic. It is called mid-systolic click, followed by a late decrescendo murmur. This is a late decrescendo murmur. Why this click occurs? Because it is in some extra redundant tissues that whenever when the mitral valve closes, it produces that click. So it is due to sudden tensing of the chorda tendineae as the mitral valve leaflets prolapse into the left atrium. It is heard over the apex, best heard at the apex, and it is loudest just before S2. Usually it is benign, but it can predispose to infective endocarditis. It is caused by the some connective tissue disorders like SLE. It can be caused by SLE. Similarly, Ehlers-Danlos syndrome, Marfan syndrome, all these connective tissue diseases, it causes myxomatous degeneration and causes mitral valve prolapse. So mitral valve prolapse is caused by these conditions. Now there is a very important connection. If we discuss murmurs, so there is a Carvalho sign. Carvalho sign means that you can remember it by this mnemonic RILE, that the right-sided murmurs that increase with inspiration. Why? Because during inspiration, the intrathoracic pressure falls, so venous return increases. When venous return increases, the blood flow across the right-sided valves increases. It increases the intensity of murmurs on the right-sided valves. Similarly, on the left side, all the murmurs, it increases with expiration, and the right side, it increases on inspiration, because blood flow is more on the right side during inspiration due to increased venous return. But there are two exceptions. One is HOCM, hypertrophic obstructive cardiomyopathy, and the other is MVP. Why? Because in these two conditions, these increase in intensity whenever the venous return is decreased, and venous return is decreased through through leg raises, venous return is decreased whenever you stand with standing. So whenever venous return decreases, these murmurs increase in intensity. Why? Because when venous return decreases, the left ventricular cavity, it shortens in size. In Hawkam, what happens is that the venous return, whenever it decreases, the left ventricular size also falls short. So the obstruction is further increased. When obstruction is further increased, it increases the murmur in intensity. Similarly, in MVP, the same thing happens. We can discuss it here. That all of the murmurs you see, mitral stenosis, aortic stenosis, mitral regurg, aortic regurg, all of these murmurs, it worsens with increase in the venous return. Venous return is increased by all these manures, like leg raises, it increases the venous return. So the murmurs of all these are also increases. Similarly, Valsalva, it decreases the venous return. So what happens is that the murmurs improves because the venous return is decreased, so the blood flow across the valves is decreased, that's why it improves. But when you look at the Hawkam and MVP, these two are the opposite. How are these two opposite? That it improves with the increase in the venous return. When you increase leg raises happens, so the blood flow towards the heart increases, so these improves. So just remember that these two are opposite to the rest of it. It will help you in solving the MCQs. Further, another thing is ventricular septal defect. It is very important that ventricular septal defect, it produces a hollow systolic murmur. It means it is the same murmur was also produced in mitral and tricuspid regurg and VSD. So whenever we discuss about the hollow systolic murmur, the hollow systolic murmur is, or pansystolic murmur, is produced by the MR, TR and the VSD. These produces which type of murmur? Hollow, systolic or pansystolic. Similarly, if you discuss a Hawkam, MVP, aortic stenosis, MVP, Hawkam, aortic stenosis and pulmonary stenosis. All of these produces crescendo, decrescendo murmur. It increase and then decrease in intensity. And the only aortic regurg, it produces a decrescendo murmur. And the mitral valve prolapse also produces late decrescendo murmur, but with a mid systolic lick. This mid systolic lick is very important. Hollow systolic murmur is also produced by the ventricular septal defect. Why? Because there is a defect in the septum. So the blood flow is constantly increased across that defect. It doesn't matter, it is more in intensity throughout the systole. But one of the more important thing is that whenever there is a larger defect, it will decrease the murmur in intensity. So if you listen to a ventricular septal defect murmur and it is loud in intensity, then it means that the disease is not much more intense. But if you listen to VSD and it is lower in intensity, so there is a bigger defect in the septum, there is a larger VSD. So these two are inversely related, that whenever the defect size is small, then the murmur will increase in intensity. Why? Because there is a very small space and the blood is flowing through it, so it will produce a very harsh sound. But if the defect size is larger, it will produce less turbulence. So what will happen? There will be lower intensity murmur. So all of these were the systolic murmurs. Now let's move towards the diastolic murmur. In the diastolic murmurs, we discuss it includes aortic regurg, pulmonic regurg, means the regurg of the superior valves, and the stenosis of the inferior, the mitral stenosis and the tricuspid stenosis. And the diastolic murmurs are always pathological. So the first one is aortic regurg. What happens in aortic regurg is that the aortic valve is leaky. So the when systole happens, it does not close completely. So some of the blood trickles down into the left ventricle. So it increases the left ventricular size as the time passes by. So what happens is, it happens in the diastole soon after the S2, and it is early diastolic. It is decrescendo. Aortic regurg produces decrescendo sound, and similarly mitral valve prolapse, it produces late crescendo murmur. So you have to do not confuse these two. One is systolic and other is diastolic, and one has a mid systolic click and the other has no click. So early diastolic decrescendo high pitch blowing murmur, and it is produced at the base of the aortic root and the left sternal border. So what are the causes? You can remember with this mnemonic: bicuspid aortic valve. Bicuspid aortic valve was also producing another disease. Which one was that? Aortic stenosis, but that was calcified bicuspid aortic valve. Similarly, endocarditis, aortic root dilatation. This is very important. Whenever the aortic valve root dilates, it will cause regurgitation, murmur, and rheumatic fever. And the very important thing is that there is hyperdynamic circulation. That hyperdynamic circulation causes wide pulse pressure. What does it mean? It means that when there is systole, the pressure rises too much, and when there is diastole, the pressure falls too much. So the pulse pressure between the two increases. Why? Because when the valve is leaky during systole, that blood flows into the left ventricle again. When the blood flows into the left ventricle, when the next systole happens, the left ventricle tries to empties the blood that was coming in the left ventricle from the previous systole as well as the current systole. So it pushes that blood with much more higher force. So every time it pushes blood, it causes wide pulse pressure. That wide pulse pressure causes head bobbing. Head bobbing, what does it mean? That the head you see that the head moves with every systole because of the wide pulse pressure. And it also causes pistol short femoral pulses and Quincke's pulse, that the nail bed you feel it that it is pulsating. So all these signs that are associated with aortic regurg. But you have to remember that sometimes it is not much more in intensity because it is diagnosed quite earlier. But if you do not diagnose it earlier and it is very advanced disease, only then it will cause these kind of symptoms. We call it Corrigan pulse or water hammer pulse. Water hammer pulse means that the pulse rapidly increases, and when you check it in the brachial artery and you move the arm along with it, and you suddenly on moving down the arm, the pulse rapidly disappears. Why? Because it is water hammer pulse. It rapidly collapses. So the rapidly collapsing pulse is called water hammer pulse or Corrigan pulse, that happens in aortic regurg. It is also associated with some other conditions. So all these signs: head bobbing, pistol short femoral pulse, wide pulse pressure, Quincke's pulse, water hammer pulse, all these are associated with hyperdynamic circulation. Sometimes they happen in pregnancy as well, because that is also hyperdynamic condition. So and eventually it leads to left ventricular hypertrophy, and eventually left ventricular dilatation and heart failure, and it is no longer able to pump the blood because it is dealing with very high pressures. Now, mitral stenosis, it is also very important. Mitral stenosis, it causes diastolic murmur. It is followed by a diastolic an opening snap followed by a diastolic murmur. So what happens in mitral stenosis? That due to immune mediated damage to the mitral valve, in rheumatic heart disease, in the streptococcal antigen, it cross reacts with the valve and it leads to scarring of the mitral valve orifice. So what happens in the mitral valve is stenosed, then the back pressure rises, that left atrium and left ventricle. So then this mitral valve is stenosed, the pressure in the left atrium increases. When the pressure in the left atrium increases, it increases back pressure as well, so pulmonary pressure also increases, which leads to pulmonary congestion. So a long-standing mitral stenosis can eventually result in pulmonary hypertension, and eventually it can cause right heart failure as well, because the most important cause of the right heart failure is the left heart failure. And it can also cause atrial fibrillation. Atrial fibrillation because when the left atrial pressure is constantly rising and the blood remains stagnant here, and that causes atrial fibrillation. So sometimes it is asymptomatic until the valve area is reduced approximately to 1.5 centimeter from 4. Normally it is 4 to 5 centimeter, but when it is decreased this much, it causes symptoms. So what happens is any condition that increases the blood flow across this valve, for example exercise, etc., it causes angina, heart failure, syncope. All these happen. Similarly, paroxysmal nocturnal dyspnea can also occur, or orthopnea can also occur, because it increases the blood flow in the pulmonary vasculature, and so that pulmonary congestion is responsible for all these symptoms. A very important thing which we discussed in the cardiac anatomy as well, that whenever the mitral stenosis happens, the left atrium, it increases in size. When it increases in size, it presses against the vessels. When it presses against the vessel, the small bronchioles, so hemoptysis occurs. And there was a syndrome associated with it as well, Ornat syndrome, that whenever it increases, it also causes dysphagia. It presses against the esophagus as well, so dysphagia also happens. So the murmur is opening snap followed by a diastolic rumbling sound, and the interval between these two, it correlates with the severity of the disease. What does it mean? That if the opening snap is happening nearer to the S2, it relates towards a severe disease. When it is happening late, it correlates that the disease is not much severe. So whenever the interval between the two is decreased, the intensity will be increased. So these two are inversely related. So it is a sequel of the rheumatic fever. Similarly, it causes left atrial dilatation, pulmonary congestion, hemoptysis, Ortner syndrome. We discussed in the first video as well, hemoptysis, and eventually right heart failure. So aortic stenosis, the mitral stenosis, it causes increase in the left atrial pressure. So the left atrial pressure increased too much even during diastole. Now what happens in the if there is a murmur which is throughout the systole and diastole, it is called continuous murmur. Such murmur happens in the patent ductus arteriosus. It has a machine-like murmur. It is best heard at the left infraclavicular area, and it is loudest at the S1UC. Here it is the loudest. So why it happens throughout the systole and diastole? Because whenever the ductus arteriosus is patent, it is not closed, so the blood is constantly moving from aorta towards the pulmonary artery, whether it is systole or diastole. So the pressure difference between these two always exists. When the pressure difference between these two exists both in systole and diastole, what happens is there is a continuous machine-like murmur. So it was all about murmurs. Thank you so much.